Good evening, good afternoon, wherever you're joining us from around the world. Welcome to our 18th Migraine Masterclass, hosted by the Association of Migraine Disorders and IVPN NeuroPsychiatry. We are very, very happy to have you with us tonight on our last webinar for this season. Tonight's event is very special because we are ending with one of the subjects that we received a lot of requests from our members asking for further education on the subject of migraine and mental health and the comorbidities that exist and management. As I said, this is the last of our of this season. We will be coming back to you after the summer break. We are taking a small break, and then we will be coming back around the fall. We will please keep an eye on our social media, on our website for the new dates for our new masterclass. Again, thank you very much for joining us. Tonight's session will be two parts. The first part will be with Dr. Lex Denisenko, who is going to talk to us about bridging migraine and mental health and integrated treatments, and then followed by Dr. Mohammed Al-Hatou, who will be talking to us about the continuum of acute versus preventive and how we're going to actually, how the lines are blurred now between the two. And of course, this session is with the very generous support from our partners, Pfizer, and we're looking forward to more support to our participants and our speakers, and thank you very much. So to start with, I'm just going to introduce you to Dr. Denisenko. Dr. Denisenko is currently an assistant professor at the a clinical assistant professor with dual appointment in the Department of Psychiatry and Human Behavior, academic, and the Department of Neurology, clinical, at the Sidney Kimmel School of Medicine at the Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. He is also the director of inpatient headache behavioral medicine at the Department of Neurology at Thomas Jefferson University Hospital. He is licensed as a general psychiatry. He's licensed in general psychiatry, psychosomatic medicine, and headache medicine. Of course, a member of multiple professional and scientific committees and societies, and a long list of publications. And I'm hoping you will enjoy this this session as much as we're anticipating. And I'm just going to remind you that all your questions need to go into the question and answer section of the meeting. So if you can see it on your screen, it's a Q&A section. Please go ahead and put your questions there. And I will be addressing the questions to Dr. Denisenko after his session, and then for Dr. Al-Hatou after his session. So if you have any questions for Dr. Denisenko, please put them in the Q&A, and I will be directing these questions at the end. Again, thank you for joining us. I'm going to say a quick thank you to our team behind the scenes. We have Kylie Petraka from the Association of Migraine Disorders, Hussam Salamat from the IVPN network, and Maya Zainuddin. And I will see you after the end of this session. Dr. Denisenko, welcome, and I will leave the floor for you.
Thank you, Haba. Okay. Well, thank you so much for having me. I'm Dr. Denisenko. Yes, I'm a psychiatrist, and for the past 6 years, I've been the embedded psychiatrist within the Jefferson Headache Center in Philadelphia, where we have both outpatient as well as an inpatient unit. We do infusions of things like ketamine and lidocaine to help abort status migrainosus. I think there's only about 700 experts in headache in the United States, and only 2 of them are certified in headache medicine who are also psychiatrists. So if you know of anybody else on this that's also a psychiatrist in headache medicine, I'd love to get together because I feel like I'm very lonely. My disclosures are here. I had several years ago, I had some speaker honoraria from Teva, and I was an investigator on a study of fruminumab for major depression in patients with migraine that's in publication. I'm going to be talking about migraine primarily during this talk and psychiatric disease, but I can't focus on all of psychiatric disease and its treatments. I'll be focusing mostly on mood disorders and anxiety. I'll be talking about how they're comorbid, how the relationship between migraine and psychiatric disease is bidirectional with both affecting each other. We'll go over the core symptoms of some of the psychiatric diseases, mostly major depression and bipolar disorder and anxiety, and how in a patient with migraine, you might be approaching treatment differently, or in what ways you might be approaching it similarly to you would with someone without migraine. Psychiatric comorbidities in people with migraine it's very common. The number one is probably major depression, perhaps anxiety. Major depression in the general population is about 20%, and that's about 2 to 4 times higher in patients with migraine. Anxieties are very common in patients with migraine as well. Generalized anxiety disorder is extremely common. Panic disorder, anticipatory anxiety, they're very high as well. While bipolar disorder remains rather rare, it is fascinating that bipolar disorder in patients with migraine is actually quite common. When you look at everybody with bipolar disorder, a third of them have migraine. And if you have a family history of bipolar disorder, such as a parent, you have a fourfold higher chance of having migraine yourself. We're not quite sure why. Maybe it has something to do with similar genetic patterns. Maybe it has something to do with similar derangements in sodium or calcium channels. We don't know quite yet. If we focus on migraine, depression, and anxiety, we can see how these three diseases can really affect each other. Anxiety, for example, the higher your anxiety level is, your migraine frequency will also increase. Migraine is also associated with a decreased chance of your depression actually responding and remitting. And depression, untreated, is an indicator of poor response to migraine medications. You combine stress on top of affecting all of these by increasing inflammation and make it even more difficult to follow treatment plans and stay motivated in care, and you really have a difficulty. But even when we look at the core symptoms of migraine, anxiety, behavior, and depression are actually part of the cycle. If we take away the actual migraine attack and we look at the prodromal symptoms that could occur 24 to 48 hours before a migraine attack, we see that some patients do have a change in their mood. They become more drowsy or fatigued. Some might get euphoric, irritable, restless, and hyperactive. Talkativeness can be a symptom that some patients report. Concentration difficulties and yawning, a loss of interest in food, or they might develop food cravings, such as cravings for chocolate. And there might be other GI symptoms as well. Many of these can occur 24 to 48 hours before an attack. They're hard to predict that an attack is going to happen. After the attack, a patient might feel relieved, but they also might feel dysphoric. They might have lost energy, and soon after they recover, during the interictal period between attacks, there will be anxiety. Headache is a common feature during interictal periods of migraine. And so when a headache develops, it's a 5 out of 10. The patient's not going to have anxiety. Is this 5 out of 10 the beginning of a new migraine? Should I start taking my abortives? Should I cancel my plans today? And that anticipatory anxiety can be a major driver for increased anxiety, avoiding certain situations. And then by avoiding those situations, you might have more depressive thoughts that all you do is stay in bed and you have no social or financial impact on your family. The DSM-5 criteria for major depression is not much different than previous iterations. It asks for 2 weeks of either persistent depressed mood or anhedonia, which is a decreased interest in hobbies that you enjoy almost every day. And you need to have additional symptoms present: appetite, sleep, you're either pacing or you're not moving much at all, low energy, feelings of worthlessness or a burden on others, concentration difficulties, and then, of course, suicidal thoughts. Unfortunately, when you look at patients with migraine, so many of these symptoms can be characterized as things that occur in migraine, which makes it extremely difficult to determine whether or not someone has depression separate of migraine symptoms. Some people use the mnemonic SIGI caps to better remember all the possible symptoms in migraine. I ask that the G in guilt, uh, you'll see why that might not be a good word to describe burden on other people. When you're interviewing someone with migraine, and other people who might not have migraine, asking if you're depressed might not resonate well in a patient with migraine. And other questions, like I said before, with symptoms, that they might find that to be pan positive because of their migraine. So I try to use a more open-ended and indirect approach. And I know it's very difficult for you to be with migraine, but have you noticed that even when your migraines might be doing well, that you still have a poor mood, poor motivation, um, low energy, and a feeling of hopelessness? Rather than asking, do you feel guilty? Because if you do that, most patients will say, oh, I'm not guilty of anything. You really do want to say, do you feel that you're a burden on your family? Right? Do you want them not to worry about how you're actually feeling so you don't really tell them? And this goes for both migraine as well as depression. Both of these disorders have high stigma. And people might not understand what depression is. People might not understand what migraine really is. So this can be also a very good uh, kind of approach to help really determine if they have good social support among their family. Do they need more education in the family about what their migraine actually is like and what their depression might be? I think that migraine patients don't like to be told that this is all in their head. And it's a very Victorian concept that women with migraine are just bad mothers, or they just don't know how to handle stress, or a man with migraine is either just working too hard or has some kind of effeminate qualities to them. So we really have to avoid those kinds of stigmas. It's true that depression can make migraine worse and migraine can make depression worse. But I often encounter people, even in my psychiatric profession, that they really wonder that is all their migraine just a symptom of their depression? And so rather than saying that, I sometimes might ask, just imagine if we could magically remove your migraine disorder, what are your chances that you would actually feel better? And sometimes people say, oh, absolutely. If it was gone, I wouldn't have any depression. I never did before. Uh, Others might say, I don't know, actually realistic. I think it would be better, but I still think there's a 50-50 chance I might still have depressive and anxiety symptoms. That, while that's not particularly diagnostic of anything, that might help you really feel more encouraged to consider an intervention for depression and anxiety. Suicidal thoughts are something that a patient with migraine might not want to answer because, in my experience, I feel that a lot of patients, particularly in the first year where episodic migraine might transform to chronic, that they do feel life is not worth living. When they see all of their friends graduating college, getting married, having jobs, and they're still at home, this can have a lot of suicidal thoughts. I try to open it up by saying, look, sometimes some patients, when their migraines are really bad, they feel like going to sleep and not waking up, or uh, life is not worth even, or even maybe even taking their own life. I'm not sure if that's the case with you, but has that ever happened for you? And when the headache gets better, do those thoughts go away? How fleeting are those thoughts? How do you make them go away? Do you talk to people about it? And that can really kind of open up to more universalize how these symptoms might be for them. Have you ever had a diagnosis of bipolar disorder? This is a case where I might ask this question flat out. Bipolar disorder, as I'm going to talk about actually for a lot of this talk, is often under diagnosed or misdiagnosed as unipolar depression. Bipolar affective disorder, I'm not going to go into the detailed criteria, but the DSM describes three, type 1, type 2, and other, as well as all kinds of subtypes. Type 1 bipolar affective disorder is the one that has mania that typically lasts for days. The criteria wants at least a week. Patients with bipolar type 1 are often hospitalized psychiatrically for their mania. It's a very severe illness. Type 2, I've always found fascinating. The diagnosis seems to be what it is not, as opposed to what it is. It's not type 1. The manic symptoms are less than a week, or the symptoms are kind of mania, but they're not as severe, and we'll call them hypomania. But even if they're hypomania, they might last longer than a week. Patients with bipolar disorder type 2 might have hypomanic episodes so short they don't even get hospitalized for them. And that's important. Uh, I'll discuss it a little bit more how it pertains to migraine. Rapid cycling is not a kind of bipolar. It's actually a transitory period that a patient with bipolar might enter into or might get out of. It's described as 4 episodes within a 12-month period. So that could be a combination of either manic episodes or depressive episodes. Most people with bipolar have about 1 or 2 episodes per year. So 4 would be a significant increase. And while that's a very serious cycle, it's more common in bipolar 2 than bipolar type 1. And here's the interesting part. People with bipolar and migraine are more likely to have rapid cycling. So we really have to take care in patients who might have this. A big myth that I often have students feel that they've believe is that antidepressants flip you into mania. A flip is something that sounds very quick and obvious. It's not quick and obvious. If antidepressants flipped you into mania, there'd be somebody out there proposing that we use antidepressants as a litmus test in patients where we have diagnostic questions if they're bipolar or not. But it often does not happen that way. More often, it's an indolent course, a subacute course that could take weeks to develop. And it doesn't turn into a frank mania. It oftentimes is irritable, angry. They're picking fights with people. It might also cause rapid cycling to develop, or it could make rapid cycling worse. And if it's something that takes that long, and then you ask the patient, have you started anything new? They might not consider the medicine that they just started 12 weeks ago as a new medicine. So it really requires a lot more history gathering. Just because an antidepressant or any medicine for that matter makes a mood exacerbation occur, our current DSM criteria allows us to call that bipolar disorder, or it could allow us to call that medication-induced mania. It's really up to the clinician to decide whether or not it's indicative of a bipolarity or not. Risk factors for antidepressant-induced mood exacerbation are abundant, but the most probable risk factors are tricyclic antidepressants and antidepressant monotherapy, meaning no mood stabilizer is being used, such as lithium, an atypical antipsychotic, lamotrigine or valproic acid. And possible risk factors, maybe bipolar 1, rapid cycling, some suggest yes, some suggest no. Substance use disorder, there have been some studies said yes, others only showed it to be more prevalent in alcohol use disorder. But substance use disorders and alcohol use disorders have so many factors involved. There's so much chaos in those disorders. It's really hard to really determine how much is influencing bipolarity and antidepressant-induced mood exacerbation. And anxiety is also such a broad term. We can't ask a patient with bipolar disorder if they've ever been manic for many reasons. One, like this prospective study where they looked at thousands of patients over an average of 14 years, the amount of weeks that are spent in either a hypomanic or manic state are very, very small. And most people with bipolar disorder are either in a depressive state or a euthymic state. So asking someone to remember that time many years ago when this occurred, they might not have any recall, and they might not have any insight. Bipolarity really suffers from insight. Patient could be manic and hospitalized, and you ask them a year later, they said, that was just a misunderstanding. I was feeling great. The problem was somebody else called police to the door. So insight can be a real issue here. So what do we do? Well, we still need to rule out bipolarity in patients with migraine before we start a medication that might actually cause their symptoms to get worse. And we love to use tricyclic antidepressants and serotonin reuptake inhibitors, norepinephrine serotonin reuptake inhibitors in migraine because they might have preventive benefits. Some of this I mentioned already before, but patients who have bipolar and migraine are more likely to have an earlier onset of bipolar disorder, greater psychosocial impairment, that's probably a given, higher rates of suicide, almost as much as you might think in cluster, and more severe and more frequent mood episodes. Mania has a lot of symptoms and signs in it. Often it is described in the mnemonic dig fast. They might have distractibility, a decreased need for sleep. You have to make sure that it's a decreased need for sleep because a lot of patients might have poor sleep because of pain or anxiety, but they're still very tired. A patient with mania doesn't feel tired. Grandiosity, racing thoughts, and flight of ideas. Those racing thoughts, they have lots of big ideas. It's not that they have racing thoughts about anxiety things. Speech might be so pressured you can't even get a word in edgewise. And they might have more risk-taking behavior, sexual activity, excessive spending, and now in today's day of age, social media presence increases. But dig fast is not a screen for bipolar disorder. My students will say, well, he doesn't have bipolar, he was dig fast negative. That's not a thing. What else can we do to try to determine bipolar? There is a mood disorders questionnaire, which is validated and for identifying patients with bipolar disorder, but it's mostly helpful in bipolar type 1. It is harder to detect bipolar type 2 and has a positive predictive value of only 15%. I do try to look at these risk factors for bipolar disorder to help us determine a family history of bipolarity in either children or parents is helpful, or siblings. Depression with additional features. A depression that's so severe that it has psychotic symptoms. A history of medication-induced mood exacerbation, and I try to have the patient try to expand their horizon, that this is not just psychiatric medications. What about antibiotics? What about birth control pills? Did any of that kind of stuff make you suicidal? You know, steroids might be the one exception. So many people with steroid-induced psychosis or steroid-induced agitation I don't think that by itself would be very helpful. Postpartum psychosis, which is different than postpartum depression, because postpartum psychosis involves real paranoid fears that someone is going to harm the baby, or you have intrusive thoughts that you might self want to harm the baby. That has also been shown to increase the chance that you might have bipolar disorder. And as I said before, potentially a history of migraine is something we should also be looking at. Dr. Hagop Akaskal, who recently passed away, was I believe from Stanford. He was a big proponent of the bipolar spectrum. Patients who don't meet criteria for bipolar 1, not quite sure if they meet bipolar 2, but they have other signs and symptoms suggesting bipolarity in the way that they respond or don't respond to antidepressants. In his prospective work, he found other soft signs of bipolarity. So for a patient who comes to you that has had a lot of depression all their life, some of these questions might help push you over the edge to consider a bipolarity, such as a strong family history, many failed antidepressants, a history of a lot of anxiety disorders or personality disorders, impulse control disorders, 3 substances of use. The number 3 was very big for him. People in the family that held eminence in certain kinds of fields. For example, if a person who's not just a lawyer, but also started his own business and also does acetylene torch welding, that might be interesting. Someone who's held multiple jobs at the same time or has had sexual relationships with multiple people, dating people at the same time, a predilection or favoritism for bright colors, particularly red. In the United States, where proficiency in more than one language is very rare, he found proficiency in 3 languages to be significant. So, none of this means anything that you're bipolar, but he hopes that this kind of history gathering might make you want to ask more questions and not be so quick to turning to an antidepressant. If you do suspect bipolar disorder and you are not a psychiatrist, refer to psychiatry for additional diagnostic evaluation. Consider a mood stabilizer first. We use valproate for migraine, although it's difficult to tolerate for a lot of patients. Lorazepam and quetiapine have the highest evidence and best tolerability in patients with bipolar depression, and they do not seem to cause migraine to get worse. Lithium does not appear to have any effect on migraine. It might help with cluster, but lithium is very helpful as an anti-manic agent and as a mood stabilizer. While lamotrigine has controversial evidence of whether or not it's helpful in migraine, perhaps maybe there's some emerging evidence it could help in people with vertiginous migraine. It is more helpful in reducing the episodes of bipolar depression. I would avoid antidepressant monotherapy and probably avoid tricyclic antidepressants if I can help it. There's also some suggestion that the SNRI venlafaxine might also be associated with more chances of mood exacerbation with antidepressant monotherapy in bipolar disorder. But if you have ruled out bipolar disorder, then you should definitely start an antidepressant if they have major depression. And this treatment will work better when taken together with psychotherapy. I'm not going to be able to have time to talk about psychotherapy here, but psychotherapy of any kind of modality, whether it's CBT, traditional supportive psychotherapy, acceptance and commitment therapy, or dialectic behavioral therapy, having that help will make the medicine work better. So what antidepressant do you choose? I mean, these are our 4 top classes. The serotonin reuptake inhibitors are a gold standard for anxiety. It's where we generally turn to for depression because they're better tolerated than most other agents, except for perhaps bupropion, but they won't help migraine. There was some initial suggestion that maybe fluoxetine would be helpful, but there's other studies that show that fluoxetine was not helpful for migraine. Maybe fluoxetine is helpful for tension type headache. Bupropion has very few side effects. It might also help with some attentional components, like a augmentation agent in attention deficit disorder. It might also help with anxiety, particularly if the anxiety is related to a depression. But 27% of people report headache on bupropion. And in our practice, it's really hit or miss. I've had patients with migraine who say bupropion is something they've taken, it has not made their migraine worse. And I've had other patients that say, oh no, I can't take bupropion, it made my migraine worse. So it's not the first thing I might turn to, but there are many patients who do find benefit on it. Mirtazapine, which has its own mechanism of action that's different from the others on this list, it has side effects of sedation. It might help nausea because it has mild antagonism at serotonin 3, similar to ondansetron. And it might help with chronic tension type headache, but it's not something I generally turn to. So then the question is, do we try an SNRI or tricyclic, since these might also help with migraine? And as you can see, that is a good option, though they might have a little bit more side effects than a serotonin reuptake inhibitor. SSRIs, serotonin reuptake inhibitors, are first-line agents for many depression disorders, including major depression, and also anxiety disorders, including panic and generalized anxiety. Buspirone, which is not an antidepressant, it's a agonist to the serotonin 1A receptor, has been approved for decades for generalized anxiety disorder. Mostly it's probably helpful as an augmentation agent for someone who's already on an antidepressant, since the serotonin 1A receptor is really the one that's most implicated in anxiety and depression. And it is usually very devoid of side effects. Even though a headache is listed as a side effect, in most of my patients, they tolerate it very well. Its problems of use is that you have to take it twice a day or 3 times a day, and you have to really increase the dose from 5 milligrams twice daily to probably 15 or 20 milligrams twice daily before it starts having effectiveness. Only one small study showed that it might have decreased migraine frequency, and I haven't really noticed that in patients. Tricyclic antidepressants for migraine are dosed much lower than the dose for depression. And of all the tricyclics, amitriptyline has the most evidence and is probably the most effective. And when you take it to doses of 100 to 150 milligrams, where at that point you also want to do blood tests to make sure you're within the therapeutic window, it appears to be the most efficacious of all antidepressants. But it also has the highest problems with tolerability. The reason why you have to do levels when you get to amitriptyline to that dose is that it affects sodium channels, which affects electrical conduction in the heart that can cause a lethal arrhythmia. In fact, amitriptyline and other tricyclics can be lethal in overdose. If you simply took perhaps 1 to 2 weeks worth of a tricyclic in an intentional suicide, that can be very deadly. That is not the case with other antidepressants. Other tricyclics have been used for other indications. Clomipramine on the bottom of the list is the most serotonergic. It's our gold standard for obsessive compulsive disorder, which needs a high level of serotonin. It does not appear to be much help for migraine. Nortriptyline, which is the active metabolite of amitriptyline, might be a little bit better tolerable than amitriptyline. It's more activating, and it's probably effective in migraine prevention. Some patients that did find amitriptyline or nortriptyline helpful for migraine, but still too sedating, my colleagues might turn to desipramine or protriptyline, which are the most noradrenergic of the tricyclics, and they might be helpful, but there's low evidence for them. Tricyclics and SNRIs both are reuptake inhibitors of serotonin and norepinephrine, but tricyclics are dirtier with more anticholinergic, more antihistamine, and more sodium channel blocking properties, which makes them more difficult and more intolerable. SNRIs might have more GI upset and nausea and more problems with insomnia. About 10 to 15% might have insomnia. And sexual dysfunction is something they share in common with SSRIs. Some people think that SNRIs are more helpful for depression, that they're stronger, but actually they're not that much better than an SSRI for depression. And they seem to have the same efficacy for anxiety compared to SSRIs, even though we consider SSRIs the gold standard, probably because we worry that an SNRI might make some people with anxiety too jittery. Within the class of SNRI, the ratio of binding affinity to serotonin and norepinephrine is quite different. Venlafaxine and duloxetine and desvenlafaxine are more serotonergic than noradrenergic, and these three share in common the sexual side effects and weight gain of other SSRIs. Venlafaxine does not have a dose-response relationship, meaning the low doses are mostly serotonergic, the higher doses are noradrenergic, and the really high doses can have dopamine reuptake inhibition. While duloxetine and probably desvenlafaxine appear to affect serotonin and norepinephrine regardless of the dose. But then when you look at these newer agents, milnacipran and levomilnacipran, which both in the United States are still brand name, they have a lot more noradrenergic potential. That causes them to have a different side effect profile, such as more insomnia, jitteriness, maybe hypertension, but no weight gain and sexual side effects. They're also metabolized in a different way, which might be more helpful or favorable for someone who might be a poor metabolizer of certain enzymes. Differences between venlafaxine and duloxetine. Venlafaxine turns into desvenlafaxine through 2D6 metabolism, and in a patient who's a poor metabolizer of this enzyme, it might not be a favorable agent. And while we do try to use venlafaxine, it might be harder to taper off because of its short half-life. While duloxetine is generally better tolerated, it does have a higher incidence of nausea. It might inhibit 2D6 metabolism of other medications, though not a significant amount, it's still moderate. For depression, we don't go higher than 60, but in our headache center, we might go up to 120 milligrams for a couple of months to see if it actually improves migraine frequency and severity. Desvenlafaxine is the metabolite of venlafaxine. I haven't been very happy with this medicine, which is marketed as Prestique, because it doesn't seem to work as well for depression compared to venlafaxine. Because both venlafaxine and desvenlafaxine have antidepressant properties, maybe that's why just having the metabolite is not as good. But the studies have also panned out. It seems to be really hard to prove that a higher dose of desvenlafaxine is any better than a lower dose for depression. Seems to be better tolerated, but higher medicine milligrams means higher chance of side effects. When we look at the blood level of desvenlafaxine in someone who takes 75 milligrams of venlafaxine, the equivalent blood level of someone taking desvenlafaxine would be 50. If you use that to extrapolate dose, it's possible that if we're going at 225 or 300 with venlafaxine for headache, maybe we could go up to 150 or 300 with venlafaxine. And I have no evidence to support this, but some of my patients have reported that desvenlafaxine has helped their migraine at higher doses. I've had similar success with milnacipran and levomilnacipran. Some patients do report these to be more helpful for migraine, but only so far. We have a small open label study of a couple dozen patients that showed that at a typical dose that we would use for depression, milnacipran had a reduction in headache days and migraine frequency. The population was mostly episodic, a minority were chronic migraine. Levomilnacipran, which has some benefits of its own, being more adrenergic and once daily dosing, as to this point has still no published reports. A lot of patients will think that do antidepressants cause headache? And it's actually true that it's listed as a side effect on the bottle of almost every antidepressant medicine. I joke with patients and say, look, the kids that were in college that took this medicine as part of a drug study to make some extra money really have no idea what a headache is. And a headache does not necessarily mean more migraine. A really good meta-analysis really uncovered that only bupropion and escitalopram appear to be statistically significant in their increased risk of headache. Trazodone and vilazodone had large effect sizes, but they crossed the confidence interval. I think there's something special about trazodone and vilazodone that I'll mention, and that is that trazodone, nifazodone, and vilazodone are metabolized to MCPP. This is a chemical that we feed to mice to give them migraine. Approximately 150 milligrams of trazodone would give you the same blood level of MCPP, and that appears to cause migraine symptoms in patients who already have migraine and doesn't seem to cause that much of a problem in people who do not have migraine. When they actually gave MCPP to patients with migraine compared to healthy controls, the frequency of migraine after MCPP was significantly higher compared to placebo among the migraine subjects. I have patients who might be taking trazodone for years. I've noticed that some of them describe waking up 3 to 4 hours after taking trazodone, and sometimes that's with headache. Sometimes they might have false positive urine drug screens for amphetamines, which can happen at high doses of trazodone. And while I have no real good evidence for this, it's for those patients that I think maybe you don't metabolize trazodone well, maybe it's too strong, maybe it's contributing to some of your migraine burden, and can we find something else that would be helpful for your insomnia? We actually have very little data that combination therapy with a tricyclic and another antidepressant would be better for migraine and depression than either agent alone. There was this small study that showed no superiority of low-dose amitriptyline with generally okay doses of fluoxetine. And this one, a little bit larger, showed that combination therapy of both amitriptyline and a low dose of citalopram was better for both depression and migraine than either agent alone. So it could be that you could use amitriptyline or nortriptyline together with a serotonergic reuptake inhibitor, but we always do have to worry about serotonin syndrome. So what is the risk? Serotonin syndrome is something that is very, very rare. And most of our data is only in patients who deliberately overdosed on their serotonergic medicines. Those are very obvious. Minutes to hours of taking a whole bottle, you could have agitation, a lot of behavioral symptoms, fever up to 106, dilated pupils, diarrhea, hyperreflexia. But what if someone is just taking the medicine as prescribed and they're a little anxious and have a little GI upset, and you measure their reflexes and they're 3+, they're brisk, but nothing really to write home about? Is that perhaps something on the spectrum of maybe you don't call it serotonin syndrome, but maybe it is just too much medicine? I've had patients that where reducing the serotonergic agent improved their anxiety and physical symptoms because they were on too much of it. Obviously, with severe cases of serotonin syndrome, it can be life-threatening. What causes it, we're still not quite sure. And there's actually quite a bit of myth and inaccurate research about serotonin syndrome. It appears that serotonin 2A receptors are the most severe cases, the ones that seem to cause a need for intensive care unit monitoring. While serotonin 1A receptors, which have a lot more affinity for the 2A, so they get binded to first, might have more of the jittery and hyperactive feelings. There might be other genetic factors or polymorphisms, but we still haven't figured it out. There's a theory that if you are on a serotonin blocker, such as an atypical antipsychotic, often used in augmentation of depression or bipolar disorder, it'll shunt all the serotonin from the 2A receptor, which the atypical antipsychotic is blocking, to the colocalized 1A receptor, which could actually increase symptoms of serotonin syndrome. There's other cases as well. And when you're on an antipsychotic and antidepressant, it does become hard to determine if someone's severe symptoms are due to serotonin syndrome or neuroleptic malignant syndrome. So often someone just needs to be stopped on all their medicines and try to get them better first. But when we look at our agents that we might use, the serotonin reuptake inhibitors they increase serotonin on all the receptor subtypes. The ergot derivatives that we might use in migraine also have high affinity for the receptor subtypes, but it's 20-fold less for the 2A receptor. So I view this as a therapeutic window. Yes, there are cases of convulsive ergotism, which may be a serotonic syndrome-like illness, but that's typically at very toxic levels of ergots. We have had no difficulty in prescribing an as-needed ergot derivative on someone who's already taking a serotonergic antidepressant. Triptans and lasmiditan are agents that only have agonism at receptors that have not been implicated for serotonin syndrome. Nevertheless, these agents have been reported in case reports for causing serotonin syndrome. When we actually look at huge studies, it doesn't seem to be that high of a risk. There's probably hundreds of thousands of people taking a triptan right now while being on a high dose of a serotonergic antidepressant, and they're not in bad shape. We do have to worry about it, but I think if someone is only taking 8 pills of triptans per month, you're not going to develop any sort of autoreceptor upregulation of the serotonin that might increase risk of serotonin syndrome for most patients. Lasmiditan, there's been some post-marketing suggesting, again, very similarly, very low-level cases of serotonin syndrome that may or may not meet criteria. I tell patients about it, but when pharmacies call me and tell me they won't fill this medicine, I often have to tell the pharmacist it's okay. I'm sorry I ran a little bit over, but these are the conclusions that I want to give from this short talk, which is always keep in mind in your patient with migraine and depression, is this potentially bipolar disorder? And then you really have to decide, do you want to treat it with a serotonin reuptake inhibitor that maybe won't help with headache, but could be better tolerated? Would you want to then maybe add the tricyclic to that? Or do you want to try killing 2 birds with 1 stone by using an SNRI to treat both the migraine and the depression and anxiety symptoms? I hope that you enjoy this talk, and I'll try to hang on towards the end for questions.
Hi, thank you very much. Our questions are going to be, for your section, are going to be now, and I have a few in the question and answer section, but let me quickly go over the ones that, just a few of them, so that we can still be on time, and feel free to type the answer if you would like to. But let me start with one of the questions around, is the poor response of migraine patients with depression to treatments related to physiology? Is it the stress, cortisol impacting drug efficacy, or is it due to poor patient compliance to treatments? Meaning, are they not motivated or feeling fatigued to take medication routinely? What do you think? Why is
I think
the
it's a,
response?
yeah, thank you. I think it's a lot of factors. There was actually one study that showed that motivation with depression was not a factor in poor compliance and poor outcomes in migraine. I'm not sure how they were able to eliminate that as a factor, but I still think that it is a major factor. If you can't get out of bed because of your depression, if you're too anxious to know which abortive you're supposed to take, how often and when, those can be major factors. There's a lot of stress hormones, potentially. I'm looking into potential that a different serotonin genetic, uh, a genetic polymorphism at the serotonin cert gene might uh, change the way you react to antidepressants, and maybe it puts you at higher risk for migraine. But I think that ultimately for your patients, you have to tell them that you really do need to treat these, that in your experience, you've noticed that when you've taken care of both, your patients get better. You cannot ignore one or the other just because you think this is mostly a headache problem. Um, there was a similar, this chronic stress influence the
Yep.
onset and progression of
Yeah.
migraine to psychiatric comorbidities. I'm not sure.
Mm-hmm.
It is very difficult to eliminate stress. Um, Americans are very bad at taking vacations, but studies have shown that to really reduce your levels of stress hormones, it takes 2 weeks. This is why when Americans come back from their 1 week long vacations, they all say, "Oh my God, it feels like I never went on vacation." So, you know, I don't think anybody has really looked at the study to suggest that taking a 1 month long vacation from everything in your life will suddenly improve your depression, stress, mood, and headache. Uh, I think it's a bit of a fantasy to think that a vacation could do any of those things. Um,
Mm-hmm.
and oftentimes it can actually lead you to not having the medical support and social support that you would have had you been home instead of on vacation. Um, but there are some people for whom stress is a much larger factor for their migraine. People are actually studying certain polymorphisms and genetics to suggest that stress might play a higher influence in some people with depression and how they experience pain.
Dr. Denisenko, I have one question based on my experience with my patients, and that's a little bit selfish to just put it in the middle, but I hope you don't mind. I hope that the others will find it useful. Sleep is one of the most difficult to manage with people who are experiencing migraine. When they have a lot of headache, they're really in a lot of pain, and then lack of sleep and the effect of lack of sleep has on their headache, and they tend to medicate. They tend to medicate. They tend to use more medications just to go to sleep. Do you have any strategies specifically on any of the medications that you have mentioned? I know you talked about quetiapine or mirtazapine or some of these that can help, and we see them prescribed for people with headache, but they make their headache sometimes worse. Anything that you can help us with?
Well, I definitely don't take anything trazodone or that rhymes with acetone. Um, Benzodiazepines, I generally try to avoid. Some patients say it helps their headache symptoms, particularly if they have a lot of cervicogenic,
Mhm.
muscle pain. But I really don't want them to be using benzodiazepines or muscle relaxants. Some muscle relaxants can have serotonergic properties. Um, the the sedative hypnotics such as zolpidem I generally tend not to use S-zopiclone. I believe in Europe there's also Zopiclone. Um,
Mhm.
the brand in the United States is Lunesta. This actually has some mild anti-anxiety properties in the active metabolite. So if I do need to use an agent, I might prefer that one as opposed to other so-called Z hypnotics. Uh, and you know, we on staff have a psychologist who specializes in cognitive behavior therapy for insomnia, which can be very helpful for patients. Um, Obstructive sleep apnea is so often undiagnosed, and
Mhm.
untreated sleep apnea can cause headache and depression. I've often thrown pills at patients who then get a CPAP for their sleep apnea and their depression improves. So I might refer
Same with
someone to
headache.
sleep medicine for
It's the
that.
same with headache, right? We
As long
see
as
that
they can
headache.
find a mask that doesn't make their headaches worse.
Yes.
Um,
Uh,
you know, in terms of in terms of other agents, I really might recommend complementing alternative treatments as well. Uh, Chamomile, provided at a standardized 1.2% apigenin, 200 to 500 milligrams, can be sedating without causing much side effects and can help with
mhm,
anxiety. Um, there's a German extract of lavender called Silexan, which is marketed in the United States over the counter, called Calm Aid. And
mhm.
this lavender agent, which might have properties similar to buspirone, but can help with anxiety and sleep. I've had some patients really enjoy it, and its only side effect appears to be lavender burps, which could be alleviated if you drink water with the medicine.
Not bad at all, huh? Just lavender
So,
burps. It could
you
be
know,
worse.
I really try. I use these complementary and alternative suggestions to help try to get the person away from thinking that there needs to be medicines for their sleep, um,
Mhm.
because I just don't feel like that ultimately becomes the answer for a lot of patients.
And melatonin, do you use melatonin at all?
Uh, Melatonin, believe it or not, has very little evidence in insomnia and almost no evidence for safety or efficacy of anything if used long term, meaning more than a week. But melatonin has some nice things about it. For one, it's actually chemically similar to indomethacin
Mhm.
without any of the GI side effects of indomethacin. I've had a couple of patients who have indomethacin responsive headaches, again, not migraine, who can't take indomethacin and have seen benefit at really high doses of melatonin at 20 to 30 milligrams. Uh, I personally would suggest melatonin um, really only at small doses, physiologic doses, if you will, of 0.5 milligrams. Um, Rameltion, of course, has some evidence in insomnia, and I really try to, if someone's going to need more agents for sleep, I'd really rather them followed by a sleep medicine expert because they have really access to some of the latest and greatest that are coming out the pipeline for insomnia.
I do have a few questions around cognitive behavioral therapy. If we can just talk a little bit about cognitive behavioral therapy and medication. I know there's still some questions coming. We're running out of time for Dr. Denisenko, but I hope that if you have the time to answer some of these questions by typing them, I'd really appreciate it. But if you can just give us a quick answer to the question around cognitive behavioral therapy and non-pharmacologic options like
Bio,
mindfulness, biofeedback in managing
Biofeedback,
comorbidities.
biofeedback has evidence going back to the 1970s that it can help reduce migraine burden. We do have psychologists who teach biofeedback as part of our practice, and it can be very helpful. Neurofeedback, which instead of biofeedback involves measuring heart rate and temperature, but neurofeedback involves trying to control your EEG wave patterns. There's a little bit of evidence, but I'm not that supportive of it just yet. Cognitive behavior therapy, and there's an offshoot of that my colleague Betsy Sang in New York City, she's a psychologist, she's done a lot of work on this, which is mindfulness-based stress reduction therapy for migraine, has evidence now that's increasing to help reduce migraine burden. And acceptance and commitment therapy, which might be more helpful for patients who are having difficulty accepting that they have a chronic condition, can also be helpful. It's hard to find someone who might be an expert in any of these things. I think it's very important to have good communication with a therapist so that they're not giving any false information to a patient that all of this is because of deep-seated anxieties that occurred in childhood or anything like that. But they're actually helping and working together with the primary headache provider on helping the patient get better.
Thank you very much. As you can see, the questions are still coming in, and it has been a pleasure. This subject, I don't think one session is enough, because I think there's so much to talk about, and there's a lot of questions. There are a lot of questions around comorbidities. I'm hoping that we will see you again in one of our webinars to talk about some of these conditions that you have mentioned today. It has been our pleasure, Dr. Lex Denisenko, to have you with us today. I hope that you have a great rest of day. The day is starting for you. It's almost 9 p.m. in the Middle East, and we are still very lucky to have a lot of our attendees still there and participating. And obviously, this is due to the very interesting talk. Thank you very much, Dr. Denisenko.
Thank you.
So now we're going to go to the next part of our presentation today with Dr. Mohammed Al-Hatou. Doctor, I've looked at your CV, and I am very, very happy to be presenting you today. I will start by saying that you are the present chair of the Qatar Board of Neurology and assistant professor at the Weill Cornell Medical School in Qatar. And today you are since 2020, you are the Qatar representative and board member of the Arab Board of Neurology, and you are the director of the neuromuscular division at Hamad Medical Center. I have to say I'm most impressed and most humbled by the voluntary work that you have done in missions and in humanitarian missions as a doctor. And I want to thank you for this and to say thank you very much for your hard work, not only in neurology, but also the humanitarian work that you do through the Red Crescent and all these voluntary missions that you have been very active in. So you give us all you give us all a motive to start to think about what else can we do other than our immediate patients. Thank you very much for your hard work and for all that you have been doing to patients in Qatar and around the Middle East. Thank you very much.
Thank you, Hiba, for this kind introduction. I want to thank the organizers for arranging this activity. I mean, good morning if you are in the US, good evening if you are in Qatar. I don't know, somebody gonna load my slides?
Yes, we will load your slides. And today it's very interesting. This is the last part of the, or not the last, this is the last of this series. And it's really interesting that you're going to tell us about how the lines have blurred between preventive and between acute, and specifically with a medication that can be used by both. So I'm very interested to see how practice has evolved with these new medications and your own experience. And thank you very much for accepting our invite to be here tonight.
Thank you. I'll try. Next slide.
Dr. Hussam, we have the slides up, and Dr. Hussam will be helping. Thank you.
Yeah, here's my disclosures. And next. Okay, You know, in 1983, I mean, when we talk about treating migraine, we always we repurposed the use of the medication. So in the past, for example, for acute treatment, we will use non-steroidal anti-inflammatory medication, but these were not invented for migraine. The same thing for preventive treatment. I mean, we will use Inderal, propranolol, which is a blood pressure medication, or we may use an anti-epileptic medication like Topamax. So we always have been dealing with repurposed medication, and these were not specific to the etiology of migraine. For that reason, mostly they are not very effective, or patient may not tolerate it or like it. Now, in 1983, it was the first time that people described calcitonin gene-related peptide. It's a peptide because it has 37 amino acids. Then after that, we start to learn more and more about it and its role in migraine. For example, you know, Gatsby inserted an electrical stimulator in the trigeminal ganglia of cats. And he noticed that if he stimulate the trigeminal ganglia, there will be a surge in CGRP. Then in vivo, if you add CGRP to the blood vessel, they noticed that it caused dilatation of the vessel. Also, they looked at CGRP level in normal people and migraineurs. Outside of the attack, the level were low and similar to the non-migraine patient. However, during the attack, the CGRP level doubled. So all of these indicated the CGRP probably play an important factor. Even giving CGRP to a patient with migraine-induced headache and medication that caused a drop in CGRP caused a drop in migraine. All of these suggested that CGRP maybe or probably play the most important factor in controlling headache. So in 2000, the first non-peptide small molecules. So when we talk about anti-CGRP, we're talking about small molecule and large molecules. So the first thing they went towards small molecules, and there was something called OCG-PANT that was described and was tested. It was unstable orally, so it was given IV. And actually, it has a great result in reducing or you know, controlling acute headache. Unfortunately, it was discontinued for two reasons. The most important one is liver toxicity. And then you cannot give a medication for acute headache IV. It's not very practical. So the G-PANT, because of the GI toxicity, lost interest, and scientists diverted to large molecule monoclonal antibodies. Then the second generation of G-PANT came, and they found that it's safer, and we'll discuss this in our future slide. So the second generation of the G-PANT did not cause liver toxicity. And from 2018 to 2021, multiple trials were done in G-PANT. In 2020, FDA approved it in the US as an acute treatment. Then later in May 2021, it was approved as preventive treatment. And it's the only medication currently that has an indication as an acute and chronic treatment. Next slide. Next. Okay. Now, are we satisfied with the acute treatment that we currently have? Now, you know, we always want to have the perfect or the ideal treatment to you know, stop headache. And why is that? Because, I mean, the study showed that if you have an excellent response of the acute migraine, the odd ratio for conversion to chronic migraine is only 1.9. But if you have a poorly controlled headache, the odds ratio is 6.8. So it's 3.5 times the will control. And we know, I mean, if you have few attacks, you don't that to become more and more frequent, and then you end having a chronic migraine, which is very difficult to treat. So to have a perfect medication or ideal medication, this medication has to meet a couple of items. You like to get a pain freedom within 2 hours, or a fast pain freedom, and we came with 2 hours, you know, as a time set. If you don't get pain freedom, at least most bothersome symptoms, or a pain relief within 2 hours. Then if you get that pain freedom, I mean, you want this relief to be sustainable. You don't want it to come after 6 or 8 hours, similar to what happened when you use a short-acting triptan. And then also, you don't want this medication to cause medication overuse headache. And finally, you want this medication to be safe. So if we look at triptans, which, you know, it's a migraine-specific medication that we have for a long time. If you look at efficacy of this medication, triptans, study showed that it's not efficacious in 30 to 40% of the patients. So a big majority of patients will not respond to triptan, even if they switch from different triptan. Pain relief at 2 hours was achieved only in 25 to 50%. So half or 3/4 of the patients still not getting a good response. In one study, 42% of these patients were dissatisfied with the result. So if we're talking about efficacy, there is a room, there is unmet need. I mean, if the patient responds to triptan, that's great. If he doesn't respond, which is the majority of patients, then I think there is a room to try something newer. What about tolerability and side effect? 43% of patients, and remember this number, 43% of these patients had side effect. And that can also lead to discontinuation of the medication. Now, about almost 11% of patients has coronary vascular disease, and triptans is contraindicated in these patients. So there is a big unmet need when it comes to acute treatment of migraine. Next slide. For that reason, I mean, rimegepant to be used as acute treatment, it was a good idea. So the trial, which is the 303 trial, was designed to test the efficacy of rimegepant in treating acute migraine. So, I mean, they enrolled patients who are above 18 years old. I mean, of course, he has to have migraine for 1 year to be definite that it's migraine. And they looked at people who had 2 to 8 moderate to severe migraine attacks a month. Of course, these patients, you know, went in screening phase for about a month to make sure that they do have the migraine. And patients were randomized, a double-blind placebo-controlled study. Either he's going to get rimegepant, 75 milligram, to use it PRN versus a placebo. And they have multiple endpoints. There was 2 primary endpoints, which was a freedom from pain. So patient will take the medication if he has moderate to severe pain, and if he had no pain after that, then this is pain freedom. Also, the other primary endpoint was freedom of most bothersome symptoms, and there was multiple secondary endpoint that we're gonna talk about next. During that study, patient was allowed to take non-steroidal anti-inflammatory medication as a rescue medication after 2 hours. Now, as for any study, I mean, you wanna study the typical population that you're gonna see in your clinic. And if you look at the study design, I don't know if you're gonna see my arrow here. I mean, we know that migraine, there is migraine with aura and migraine without aura. And the migraine with aura is about 25 to 30% of the population. And if you look here, 28% of the patient has migraine with aura and the majority without aura, which is exactly what we see in real practice. And it was similar in both groups. About the average headache for this group was 4.6, 4.5, so that was similar. The second thing is, you know, MBS, the most common thing is photophobia, then nausea, and the same thing in our group, that what we saw in this group. So both placebo and active arm were similar, and then these patients were similar to what we see in our, you know, day-to-day practice. Next slide. Okay, so as we said, there was 2 primary endpoints that were met, and we'll talk about them. And there was 21 secondary endpoint. All of them met except the last 2. And I mean, rimegepant was more beneficial, but since it did cross the midline just slightly, then it's not statistically significant. Next slide. Next slide. Okay, so if we look at the primary endpoint, if we look at most bothersome symptoms, MBS, within 2 hours, so 1/3 of the patient has no more MBS within 2 hours, which was great, and that was statistically significant. If you look at pain freedom, which means no pain at all, so more than 1/5 of the patient were pain-free within 2 hours, which is great and which is the goal that we look for. Next paragraph. Now, if we look at pain freedom at various timeline, at 90 minutes, about 15% of patients were pain-free. At 2 hours, 21%, as we mentioned in the previous slide. At 4 hours, about 40%. And at 6 hours, about half of the patient were pain-free. And why is that? Because, you know, with the ODT, actually, the Tmax is faster by 26 minutes when it's compared by regular tablet, and it's about 1.5 hours when the medication start working. That's why you start to see more and more response with time. Next slide. Okay. What about patient gaining normal function? Because, I mean, if there is a response, then the patient, to prove it, the patient should be able to function normally. And by 15 minutes, there was almost 10% of the patient start to gain their ability to function. By 1 hour, more than 1/5 of the patient. By 2 hours, almost 40%. And by 4 hours, more than half of the patient were able to function when they receive the rimagepant as an acute treatment. Now, what about pain relief? Now, pain freedom is no pain. Pain relief is the transition from moderate or severe pain to mild pain. Like patient will have 3 or 2, he will have mild pain. And most patients are able to function when they have a mild pain, which is also good. So within 15 minutes, 8% were able to function after 1 hour or had mild pain or pain relief, 37 after 1 hour, and by 4 hours, 71% of patients has pain relief, which was great. Next slide. We said that, you know, a good medication should have a sustained benefit. So you don't want the medicine to last for a few hours. So they looked at sustainability at 48 hours, 2 days, you know, within 2 days after using the medication. So with the rimagepant, 13% had pain freedom, you know, for 2 days, and more than a quarter of the patient sustained the ability to function for 2 days after taking the medication as an acute. And this is one of the secondary endpoints. Next slide. If we talk about pain relief, I mean, 42% of the patient had sustained pain relief, you know, up to 48 hours, versus only 25% of people who took placebo. And this was statistically significant. Next. Now, people who achieved pain relief within 2 hours, 71% of them kept that pain relief for 48 hours, versus only 58% of patients who are taking placebo. So usually, if you achieved pain relief, there is a big probability that you're going to keep it for 2 days at least. Next slide. And interestingly, that 86% of the patients who took rimagepant did not take rescue medication, since probably their headache got better within 24 hours versus 71% of the placebo, which also was statistically significant. Next. Now, triptans also work in lowering CGRP during the attack, proven by the studies. So what if the patient failed triptan? Is rimagepant gonna work? If there is, response to triptan, can you send you to any direction? Actually, studies, if you look at the first, if you look here, I don't know if you see my arrow, probably not. So if patient is naive for triptan, the response was about 20% for pain freedom, and 35% had the freedom of MBS. Now, patient who failed one triptans, again, the response was about 20%, and patient who failed 2 or more triptans, the response was 20%. So pain freedom was almost the same, regardless if you failed triptan or if you did not. Now, if you look at MBS, naive patient 35.5, failed 1, 36. If you failed 2, actually, the response was even better. So regardless of failing a triptan or not failing a triptan, you can use rimagepant. I'm not showing the study, but also it showed that if patient use triptans, for example, for acute attack, you can use rimagepant soon if patient did not respond to rimagepant, did not respond to sumatriptan. Next slide. Now, what about safety? I mean, we said any medication that you want to use, it's very important to be safe so patient will tolerate it. When we talk about sumatriptan, we said up to 43% of the patient did not tolerate the medication. If you look here, if you compare the medicine to placebo, there is no significant difference between the two medications. I mean, if you look at nausea, no significant difference, urinary infection or dizziness, they were almost similar to placebo. Next slide. Now we're going to shift gear now and talk about preventive treatment. We said before that, we used to have repurposed treatment for migraine prevention until the monoclonal antibodies came, which was a great invention and a great add to what we have. But still, there is unmet need since, it has long half-life. It lasts up to a month. So, I mean, when you start it, if patient is allergic, this allergy gonna last for a month. So if there's any side effect, this side effect gonna last for a long time. There is about 1/3 of the patient will report wearing off response. So whenever I try ironimab or Emgality, my patient first visit, he's happy with the response. Some of them, after second or third visit, they will complain that the medication effect is wearing off or not lasting the whole 4 weeks. Also, there is some patient who prefer taking oral tablet than injection. And of course, the sub-Q injection, can cause local injection site reaction. So there is also unmet need even with the monoclonal anti-CGRP that we have. Next slide. So, I mean, rimagepant was tested as a preventive treatment, not only as an acute treatment, but also it was tested as preventive treatment. And next slide, in a study, 305 study. And this study, again, they enrolled people who are above 18 years old, people who had migraine for more than 1 year, and they looked at, people who are having 4 to 18 migraine attack a month. During the observation period, to set their baseline, patient has to have 6 or more migraine days a month. So patient either gonna get rimagepant 75 milligram orally every other day versus placebo, and that was the primary endpoint was the change in monthly migraine days from their baseline. The study was for 12 weeks, and they measured the response in week 9 to 12, which is month 3. And then there was an open label extension for about 52 weeks. Next slide. Now, if you look at, the primary endpoint, which was a reduction of monthly migraine days during the last month of the study. Rimagepant resulted in less 4.3 days a month of headache versus placebo. So if the patient, for example, has 8 headache day a month, in an average patient half their number to 4 headaches a month. Next slide. There was multiple other secondary endpoint. They looked at 50% responder also, and that was significant. They looked at the change in mean number of total migraine days per month, not only in the last 4 weeks. They looked at that from the first week to the last week, and also that was significant, statistically significant. Rescue medication use in the last month that did not meet, it was not statistically significant. A change in mean number of total migraine days per month, even in the first 4 weeks, that also was significant. The only thing that was not significant also was a change in MEDASA score, which did not meet statistically significance. Next slide. So if you look at the curve of the change, you can see a fast separation between the placebo and active medication from the start. Here at 1 month, you can see the big separation, and this separation sustained at the end of the 3 months. Even from first week, there was 30% reduction in migraine compared with the placebo. So this indicates that, even for prevention, the response of the medication is very fast, which is great. So from the first week, there was 30% reduction of migraine days. And we know that because, the Tmax of the medication with the ODT is achieved within 1.2 hours. So the medication will start its efficacy fast, because we know that this medication also is indicated for acute treatment, which is a great point. You don't have to wait for a month or two to get a response. Next slide. Now, what about the open label study? If you look at the curve, there is continuous reduction of the monthly migraine days with time. By the end of the 1-year open label study, there was 6.2 headache days reduction a month with the use of Rimagepant. So the benefit did not fade away with time. Actually, it's the opposite. Next slide. What about tolerability and side effect? Again, there was no major significant or major side effects increase with the medication compared with the placebo. If you look at mild adverse event, 25% in placebo and 25% in Rimagepant. If you look at moderate adverse side effect, again 17% versus 17%. Drug-related side effect 11 versus 9. So there was no significant increase or significant difference when compared with the placebo. Next slide. Now, as we mentioned in the first generation Gepant, there was concern about liver function and liver toxicity. So 4% or 4 patients out of 371 patients, which is about 1% of patients who received Rimagepant, and 2 or almost 1% of people who received the placebo had ALT or AST elevation 3 above upper normal limit. Now, 1 patient on Rimagepant, which is about 3 in 1,000, had an elevation of aminotransferase more than 10-fold of the upper limit of normal. Now, in this patient, alkaline phosphatase and bilirubin level always were within normal. There is one patient who had elevation in bilirubin, but it was not related to rimagepant. When further testing was done, they found that patient has Gilbert syndrome, and that what was causing the elevation in his bilirubin. So it wasn't the medication, it was just a coincidence. Next slide. Now, a challenge make trial. It's very interesting. It's a trial. Eli Lilly, which make Emgality, think they are the 600 gorilla that nobody can beat them when it comes to migraine prevention. So they decided to do this trial. So it was designed hoping that it will show superiority. It will show that they hope that Emgality will be superior to rimagepant in this trial. And they designed this and paid for this trial. Next study. Next slide. So in this study, of course, there was a screening period for a washout, and then there was a period to capture the baseline. The patient will fill the diary to see his baseline before going in the trial. Then patient either gonna get galcanezumab, and first time he will get a load, so he will get 240 milligram plus placebo tablet, or patient gonna get rimagepant plus placebo sub-Q injection. And the primary endpoint was 50% or more responder rate. And there was secondary endpoint looking at 75% responder rate and a change in monthly migraine headache. Next slide. And the shocking result was, 50 or more responder rate, 62% had 50% or more reduction in their headache in the galcanezumab arm, and 61% in the rimagepant arm. So the study showed that galcanezumab is not superior and rimagepant is not inferior to the other medication. Next slide. Next. Now, if you look at safety, between the different medication, just I want to highlight two important things. We know that irinumab can cause constipation. There was 0 patient having constipation with rimagepant. And also, irinumab can cause mild elevation in blood pressure. And there was no vital sign increase in either of the medication in the trial. Also, there was no change in lab parameters in both studies. Now, one patient in rimagepant has PE, pulmonary embolism, but when they opened that chart, they found that patient already had PE before. So the investigator felt that this is not related to the medication, just they enrolled the patient who shouldn't be in the trial. Now, what about long-term use of rimagepant? Is it safe or not? Next slide. This study looked at long-term use, looked at safety and patient satisfaction. Later on, we'll talk about that. So, patient either, people who, the first 2 group, they went and after observation, they received rimagepant as needed and maximum 1 dose per day as a PRN use for 52 weeks. And the last group, they went for 12 weeks in which rimagepant was used every other day, plus the off day, if patient has a headache, he may use it in a PRN, maximum 18 tablets a month. And then they looked at adverse events, serious adverse event, and labs. Next slide. And just, in a brief, adverse event leading to discontinuation was only 2.7% of the patient taking rimagepant, which is a great percent, 2% of people discontinuing the medication, comparing with a much higher rate For example, Topamax, it's about 23%. Tricyclic antidepressant is even higher because of the side effect. So 2.7 discontinuation rate because of the side effect. That was great. No significant elevation or change in lab was observed. Most of the side effects that was observed were mild to moderate, and investigator felt that it was not related to rimegepant. Next slide. Now, what about its safety with patients with cardiovascular risk? If you look at, they looked at people with 0 cardiovascular risk, 1 cardiovascular risk, or multiple cardiovascular risk. They felt that regardless of the cardiovascular risk, even people who has a high multiple risk factors, the adverse event were not higher in people who took rimegepant. So that made us jump to a conclusion that it's safe with people with ischemic cardiac disorder. However, we have to take this with precaution, since this study was not designed and wasn't powered to look at safety in patients with cardiovascular risk. Also, in the study, they excluded patients who were uncontrolled or had unstable or had acute cardiovascular incident. So these people were excluded. So we think it's safe, but we have to take this with precaution. Next slide. Now, what about preference and satisfaction? And this is very important. I mean, you want to give the patient the medication that he preferred to take, and you want to make the medication that he's satisfied with. So with PRN use, if you look at 12 weeks, more than half of the patient were preferred rimegepant compared with the treatment that they tried before as a PRN. If you look at satisfaction also, about half of the patient within 12 weeks were more satisfied with rimegepant compared with the previous medication. Now, if you look at the preventive treatment, where patient used that every other day plus PRN, majority, 74% of people had more preference to rimegepant. And if you look at satisfaction, about 70% of them were more satisfied with rimegepant when it used as a preventive treatment compared with the previous preventive treatment that they used. Now, after 52 weeks, preventive satisfaction and preference were not assessed, but when it was used as PRN, you can see up to 81% preferred rimegepant, and up to 76% were more satisfied with rimegepant, which is a great news. Next slide. Which will make your patient happy. Now, what about rimegepant use with contraceptive? Migraine attack female more than male. It's up to 16% of the female has migraine versus 8% of the male. These female usually are, in childbearing age, so they have a risk of getting pregnant. Most of them are taking oral contraceptive. So is rimegepant gonna affect oral contraceptive? We know that rimegepant is metabolized by CYP3A4 and slightly by CYP269. And actually, rimegepant and also these oral contraceptive, for example, ethinyl estradiol is metabolized by CYP3A4, and rimegepant has a mild inhibition. So is this inhibition going to affect the efficacy of these medications? So that trial, enrolled 25, but 20 completed the study. They took rimegepant with the oral contraceptive, and there was increase in exposure of the ethinyl estradiol. It was less than 34%, So that's not significant. And norgestimate, I mean, it was less than 46%, and that elevation was clinically, wasn't clinically relevant, and there was no change in lab. So it was felt that it's safe and tolerable. So there is no problem of taking rimegepant, recommended dose with oral contraceptive. Also, rimegepant has a 11-hour elimination time. So elimination of the medicine even fast because you take it every other day. So patient can take it. If she become pregnant, then she can discontinue it. So even patient who plan to get pregnant, you know, it's okay to take rimegepant. However, as soon as she gets pregnant, she need to stop the medicine. It's going to be eliminated very fast out of the system, but we don't recommend taking it during pregnancy since we don't have enough data to support that. Next slide. Next, I mean, by this slide, I mean, that's the end of my talk. And I'm ready for any question. Thank you. I finished in time.
Thank you very much, Dr. Muhammad. Can you see me?
Yes.
Yeah. I'm right here. Okay, so I have a few questions for you. I really have a couple that are very interesting. The first one is, what are the cost implications of blurring the line between acute and preventive migraine treatments? How can healthcare systems balance the cost of integrated treatment approaches to the benefits of reduced migraine treatment? And I have a very active listener today, or participant today, Hind Moata. Thank you very much. But a lot of these questions are very interesting. I hope that you will be able to help me answer them.
Great. Now, you know, it's challenging in the practice. I mean, you get a patient who come to your practice and he say, you know, I have 6 headache days a month. Are you going to use acute treatment or use a chronic treatment? Even some people say, let's try acute treatment. Let's see if we're going to break it. This is the first issue. The second issue, I mean, the more medication you use for acute treatment, triptans or combined medication, you know, if you use it more than 10 days a month, you actually classified as medication overuse. So most of the medication, except the triptans, gonna cause medication overuse. A triptan actually is the opposite. It will prevent migraine. So it has this advantage that you can use it as an acute and preventive treatment. You can start using it as an acute treatment if
Doctor, I might have misunderstood. So
yeah.
Gepant or triptan, you're saying. So can you just repeat, because I might have misheard?
Yeah, no, a triptan has the risk of causing medication overuse headache.
Yes.
And actually it's one of the, when in our practice, most of our doctors don't pay attention, but you're going to notice that your patient keep asking for refill. You know, like in Qatar, we allow the patient 8 tablets a month. And most patients will come, please, I need more. It doesn't last me. So this is an indication that patient is suffering from medication overuse. And it's a problem.
But is it only 8 tablets a month or 8 days a month?
8 days. 8 days a month. 8 days a month.
Okay, so yes. They can take
so
more and days, up to 8. Mm-hmm.
At 8, exactly. If the patient is taking it more than 10 days a month, then he's classified as migraine overuse headache. And we know, like you know, like a triptan has that risk. We know that ergot has that risk. I mean, I don't like ergot for that risk. And combination medication or medication that control have narcotic has that risk. Actually, when they start to use triptan, when they start to use Gepant, they notice that actually it's the opposite. People, you know, because, you know, Gepant was first approved as acute treatment, but then when they start to use it, they felt that it has a preventive treatment. So here, if the line is not clear between acute and chronic, shall you try both treatment or one? I mean, you are not wrong if you try Gepant and rimegepant first, and then you can escalate.
And the cost, do you feel that the cost is justified with these new medications?
Now, I mean, of course, I mean, these patients, when you see them, they saw the primary care doctor, they tried Tylenol, paracetamol. They tried, non-steroidal, or they cannot take non-steroidal. So you have two options. You let this patient suffer with the migraine and don't enjoy their life. And migraine is the second cause of life lost due to disability. So if you count the days that he lost, working or going to the emergency room or being away of his life, I think it's worth it.
And the next question then we have that also comes around monoclonal antibodies and GPANs. I see this now more and more in my practice, where a patient would be using CGRP for prevention, injectable or in infusion, and then they are prescribed a GPAN. What is your experience, and what do you think of that?
Actually, now there is a study going to come from the Gulf about combining the treatment, and it's showing that it's safe. And actually, we're seeing a synergistic effect when using both together. We're seeing more efficacy, more response, and we see safety. Also with for example, Botox. I mean, we have patients who did not respond to Botox. They went to the CGRP and they have some response. We went back to Botox with the CGRP and they got a great response. So using this medication with triptans, using it with botulinum toxin, using it with monoclonal antibody, I think it's safe and you get more response. Because remember, you wanna try for these patients to live normal life. And I think you can accomplish this with a combination sometime. So it's safe.
Sure. Then I have a question around how do cultural and regional differences impact the acceptance and implementation of integrated migraine treatments worldwide, and what can be learned from global case studies where integrated migraine treatment approaches have been successfully implemented? I know the whole idea of a holistic approach to migraine is something that has always been there. Do you think that our region differs from the rest of the world in how patients accept holistic approaches?
It's an interesting question. I practiced like 25 years in the US, then I moved to Qatar in the last 7 years. Now, there is some medication I saw significant difference. For example, topiramate in the US, people tend to tolerate it more, and I get good response. They tend not to tolerate tricyclic antidepressant. When I came to Qatar, people do not tolerate topiramate. I mean, they get crazy with topiramate. They get depressed. Tricyclic antidepressant, they tolerate it more and they get a better response. However, when it comes to the GPAN, I mean, the response is great here. So I don't see a major difference between the West and the East when it comes to these medications. Of course, there is some burden because of the cost in some countries. Some people cannot afford it. So in some big country, I mean, like Egypt or India, it's expensive. It's very hard to afford it. Yeah, but I mean, I think if you look at, if you compare it with other medication and look at the safety profile, I think it's worth it.
And in your clinic, do you have also psychologists, psychiatrists, physiotherapists? Is this in the way that you manage migraine? Is it multidisciplinary, or is this a pure neurology clinic and people have to go elsewhere? Can you just let us just explain to us how your clinic works?
Yeah, unfortunately, I mean, we like it. It's better to be multidisciplinary, but it's one subspecialty show. So mostly neurology, and then we refer to psychiatry. Here we have the stigma of seeing a psychiatrist. So people don't like to see a psychiatrist.
Is there a difference between seeing a psychiatrist and psychologist with your patients? If you say, I want to send you to a psychologist versus a psychiatrist, does that differ in the stigma?
Yes. Psychologist is more accepted than a psychiatrist.
And
especially,
sorry.
Especially young female, before marriage.
It's fashionable to say my therapist said.
Yes.
I hear this more often now than when we were practicing a while ago. The next question I have is around photophobia and phonophobia. from your practice, from your experience, do you see any impact on gepants on photophobia and phonophobia?
Yes, I mean, there is an impact. Even in some people think that different gepant has different response. So,
Yes.
So I mean, some people think that, for example, lasmeditan may help more with the nausea. Ubrogepant will help more with the photophobia. Rimogepant is less sedating than other people, but these are very small studies. But all of them were tested in MBS, and all of them show efficacy. If you remember that slide, within 2 hours, 1/3 of the patient, all of the MPS disappeared within 2 hours, and most of them within 4 hours, they have no more MPS.
Okay, I have two questions. I'm not sure if it's the same. I don't have the name, but can you please explain more how gepants actually work? And meaning, how long does it take for them to work? If someone who has chronic migraine, if they take the drug for one time, any expectation how long for it to function last, and when would the next migraine attack be? So they just want to see how what the efficacy is and how long it lasts for.
Yeah, I mean, remember, it's some of the gepants are indicated for acute management, like ubrogepant. Some of them are only for preventive treatment, like atogepant, and some of them are indicated for both acute and preventive treatment, like rimogepant. So, for example, I mean, rimogepant is ODT. So, as I mentioned, it saved 26 minutes, and time is money and everything in a stroke and migraine. So when you take it as an ODT, the Tmax is reached within 1.2 hours. So it's about an hour and a quarter. Yeah. So that when that's the Tmax, that's the peak of the medicine, in the system. But it's gonna be built gradually in the system. So that's why people will start to respond even sometimes after 15 minutes as some of the study versus a placebo, but within 2 hours, that when you get real response, and then this response will increase gradually with time. That why after 6 hours we have 70% of the patient are free. Then so the response or the onset is fast. I mean, considering that you're giving a medication orally, it's not sub-Q or IV. Then the second question, how long this gonna last? The half-life is about 11 hours. So 50% of the patient gonna be eradicated within 11 hours. So that's why it's also indicated as a preventive treatment, because it lasts for up to 48 hours. Now there's a trial giving some of them like rimogepant in a daily, but we are waiting for the result of this trial.
Yes, we are still waiting for that. I'm going to have one last question, and that is the future. We are looking at CGRPs that have generated the monoclonal antibodies and gepants. What are the new target molecules that you think, or any neuropeptides that can in the future? Do we know of any of them that might be for future in the future will give us more medications to give more treatment options for patients?
Now, one of the gepant, zavogepant, is giving nasally. So I mean, the future in the route of admission, nasal spray or sub-Q may have a faster onset for acute medication, because we know that if the more delay in the peak, the less response you're gonna get. That's regarding the gepant. Probably more and more forms gonna come out. Now regarding other molecules, now there's a study about different molecule. I'm blanking on the name. That also showing promise in using for migraine. It's completely different than gepant.
Okay. I would like a lot of the questions we have addressed in other sessions. So if you still want to learn more, we have a very rich library. If you go to the chat, you will see that the Association of Migraine Disorders have provided us with many references that we can go back to for more information. And the IVPN library also has all the other sessions that we have posted with videos and with, again, resources that can enhance your knowledge on the subject. Dr. El Hatou, again, it's a pleasure to meet you. And it has been a very, very interesting and very informative session. We really thank you for joining us today from Doha. And we wish you, I'm going to wish everybody Eid Mubarak in the Middle East if you're celebrating Eid Mubarak. And of course, for the rest, happy weekend, and see you after the summer holiday. Thank you very much, Dr. Mohammed El Hatou.
Thank you. Eid Mubarak, and thank you for this.
Eid Mubarak. So we come to the end of tonight's session. Thank you very much for joining us. As you can see on our screen, we have the IVPN library, which is really rich. If we haven't answered your question and answer, we apologize, and that is because of the time. But a lot of these questions, you can find answers in our library, whether the IVPN library or the Association of Migraine Disorders. As usual, I would like to thank our dear guests that joined us today, and most important, our participants and our attendees tonight. Thank you very much. We know that it's Friday night, it's a long night, and we really appreciate you being here. Special thanks to our sponsor, Pfizer Middle East, that have been very generous in continuing to support us in bringing experts from around the world and the region to share their experience on migraine with you. And behind the scenes, we have Kylie Petraka, we have Hussam Salamat, and we have Maya Zainuddin. Thank you again, and we hope to see you after the short summer holiday, and we're looking forward to you sending us your requests as well, your suggestions, what other subjects you would like to hear during our events. Thank you very much. There is CME. I think it's already, all the information is in the registration. If you give us your registration number, the countries that do provide CME, this will be provided at the conclusion of this event. Thank you very much, and have a very good night.
Good night.